Okay, well, welcome to chapter 20, where we're going to discuss compression with our modalities now. So let's take a peek at some of our objectives first before we really get into our main discussion here. So we're going to be discussing different categories of physical agents, in this case, compression, and the role of each of those modalities in rehab. Describe the mechanisms of tissue injury and repair. We're going to discuss some things like venous insufficiency and ulcers that form, so something you may have heard in some of your other core courses. We're going to demonstrate competency in identifying normal and abnormal changes in that integumentary system, identify physiological effects of, indications, and contraindications for compression, identify the effects of physical agents on pain relief and different functional activities, mainly looking at functional activities for this modality. We're going to look at different pertinent information in the patient's health record prior to carrying out the plan of care, and discuss and implement patient and healthcare provider safety considerations before, during, and after the application of this compression therapy. We're also going to demonstrate proper, safe, and effective application of compression. So we'll talk about when it's safe to use, when it's not safe to use, and how we really determine that. Determine when an intervention should not be performed due to clinical indications, when an intervention is beyond the scope of the PTA, and when to report changes in patient status or progress to that supervising PT. We're going to also monitor and adjust physical agent interventions within sample plan of care in response to patient status, clinical indications, values, preferences, and/or express needs. We're going to apply the principles of infection control, universal precautions. That'll be very important for our patients that are dealing with open wounds and edema that we're trying to manage. We're also going to learn how to provide education to patients, caregivers, healthcare providers, and/or consumers, and participate in performance improvement activities. So let's get into our compression here. So what is compression? Well, it's the inward directed mechanical force that increases external pressure on the body or body part. So we're going to use compression to help improve circulation, improve fluid balance, and we can also use compression to help modify the formation of scar tissue. So that'll be really important whenever we are discussing burns, whenever we're looking at possible amputees. We can use compression to help modify the scar tissue that forms and the quality of that tissue. So how do we improve this fluid balance with compression? Well, it's improved by creating what we know as, by increasing what we know as hydrostatic pressure in these interstitial spaces, so that the pressure becomes greater in the interstitial space rather than the vessels. So this term will be very important for you to know, understand. We're going to talk about it on this next slide here. So this is an example. This is an image straight from your textbook that shows kind of the importance of what we just looked at with hydrostatic pressure. And then it also talks about this other pressure called osmotic pressure. So we're going to learn a little bit about what that means. So you can see that this is your capillary here. You can see this nice flow of lymphatic fluid. This is coming more proximal to the areas here, so moving towards the heart. So what happens when we have this hydrostatic pressure is that we get a lot of pressure buildup inside these capillaries here. And the more pressure we get, the greater out of the capillaries we get. So we get flow out of those vessels due to hydrostatic pressure. All this fluid is basically going to leak out of the capillary and into this interstitial space, or this extravascular space here. Okay. We also have what we call osmotic pressure, this guy right here, that is basically counteracting that. So what is exactly osmotic pressure? Well, we call this oncotic pressure. So this is basically a counteracting force of hydrostatic pressure. We have the fluids leaking out of the capillaries with this oncotic osmotic pressure. This is actually more of a pulling force. So it's pulling fluids into the capillaries and it's really based on these protein plasma levels that we see in this capillary here. So I have a little table that's going to help you maybe understand this a little bit more. But with compression, we are trying to really eliminate or at least manage this outflow here into this interstitial space. Whenever we get a lot of leakage into this area here, this is what's going to result in edema. So we need to apply a compressive force to help the osmotic pressure, that oncotic pressure, to drive more of those fluids back into the capillaries so that it gets sent more in a proximal direction, so that it gets basically recycled in the body. Here's a couple different devices that you may see in clinic. This first one here is a Game Ready. This is a really nice intermittent compression tool, and it also has really cold ice that flows through this tube here and into the sleeve. So we get compression, and we also get the effects of cryotherapy, which is going to help reduce inflammation, possible edema in the area. These are some TED hose stockings here. So patients are going to wear these, after surgery, or if they do have some kind of lymphatic issue, to help maintain that balance of fluid regulation in the body. Okay, so let's look at maybe some of the effects of external compression here. So why are we going to use compression? Why are we going to wrap our patient with a figure-8 wrap? Well, we're trying to reduce edema first, and we're also trying to improve venous and lymphatic circulation. Okay, we're trying to counteract that hydrostatic force that's pushing fluids into that interstitial space. This is also going to be really useful in helping to prevent DVTs, and I have prevention bolded here because it's a preventative type therapy. It's not used to help treat an active DVT, and that's really important to note that. So we use compression wrapping to help prevent DVTs, but if there is a present DVT formation, we are not going to wrap that limb, okay? So that's really important. We'll talk about the reasons why a little bit later. When we use compression, this also increases the tissue temperature. So it's, basically through insulation that you're going to get that. We see enhancement of tissue healing because we're recycling, we're getting all of this fluid that is static typically back into the system, and that allows new nutrients to enter through the area, and it gets rid of all those nasty ones that are just hanging out and sitting there. Okay. We can also again use this to help reduce hypertrophic scarring. So we basically use compressive wrapping as a mold for that new tissue to grow into. So if it doesn't ever have a mold, then we may get this hypertrophic scarring where it extends beyond the initial boundary of that incision or that little wound that they have. We can also use this to help control pain. So anytime that you have edema, right, we get tons and tons of pressure buildup that presses on our arteries. It can compress the nerves, and that can cause a lot of pain. So if we get rid of that fluid, we can help decrease the amount of pressure buildup in those limbs. And we are also going to we're going to use compression to help shape residual limbs. So we have a few of our nice little models in our lab that we're going to practice on. And again, we're really helping to shape these residual limbs before they get fitted for a prosthesis. Okay, so kind of a little bit out of order there, but I apologize. So let's understand this fluid balance a little bit better. So like I said earlier, the oncotic pressure is this pulling force, okay? And that's exerted by plasma proteins that helps draw fluid into the capillaries. So again, here's our nice little capillary. This oncotic pressure is going to help drive fluids in. So here's our interstitial space out here. We don't want necessarily too much leakage into that interstitial space. This oncotic pressure helps pull in this this fluid because of this plasma proteins. Okay, so it's pulling fluid into the capillaries. Hydrostatic pressure is the one that we just discussed. It's a pushing force. It's basically going to push out into the interstitial space. this can be increased by blood pressure, just the natural pumping action of our heart. Definitely affected by gravity as well, but this is again pushing these fluids out into the interstitial space here. Okay, so these two kind of counteract each other, but we're going to learn about why this plasma protein number is going to be so important, right? If we have decreased levels of plasma protein, that'll really limit the amount of oncotic pressure that we're getting, and this hydrostatic pressure kind of takes over, and then we get lots and lots of leakage into these interstitial spaces here. So edema really occurs when that hydrostatic pressure is greater than our oncotic pressure. That leads to a ton of fluid accumulation in the tissues, edema, pain, dysfunction, you name it. Okay, so this is that table that I was talking about here. Maybe this helps break it down a little bit easier for you, maybe more of a visual for you to go back to and just continually look at, but you will need to know the difference between hydrostatic pressure and oncotic pressure and the importance of those two. So here's your force type: pushes fluid out of the vessels versus oncotic pressure where it pulls it into the vessels. Our source, blood pressure here, or just fluid volume in general, versus our oncotic pressure here. We're really looking at these plasma proteins. Albumin is one of the most, this is one of the most important ones that we need to discuss. So we'll again talk about this a little bit later on as well. Here's the direction. So we see our direction here. Hydrostatic pressure is outward force, so into the interstitial spaces, where oncotic pressure is driving it into the capillaries. And don't worry so much about the primary site here, but this is a nice table that you can use to maybe help understand the difference between that hydrostatic pressure and oncotic pressure. Okay, so let's talk about the role of the lymphatic system a little bit. So we have this nice image over here on the right-hand side that discusses, or kind of just visual, it gives you a visual for where all of this lymphatic tissue lives. So everything green here is going to be our lymphatic system. So you're basically going to have lymphatic tissue everywhere where you have blood vessels, capillaries, veins, arteries, things like that. So we're going to have a lot of these lymphatic tissues in those same areas. But what's the role of the lymphatic system? Well, its role is to take up this excess fluid in those lymphatic capillaries and return it to circulation through this subclavian vein. So we're going to talk about this thoracic duct here. So we'll come back to this a little bit later as well and really discuss the details of where these things drain in our body. But all of this fluid that we're trying to get rid of, all of this excess fluid that's taken up by these lymphatic capillaries, are going to be returned here or here. Okay, so that's where all of that fluid ends up. There's a couple different common causes of edema that you need to know about. Let's look at systemic illnesses first. So kidney disease, liver disease, heart failure. Heart failure is one that you may have already discussed in your pathology class, but these are more systemic issues. Okay, we'll get back to these here in 1 second. Another really common cause is venous or lymphatic insufficiency. Okay, so whenever we have venous or lymphatic insufficiency, this just means that we have poor venous return, and that leads to fluid pooling in the extremities. And when that fluid pools in the extremities, we get a lot of pressure. So that hydrostatic pressure tends to increase whenever we have pooling of this fluid in the extremities. That's going to lead to excessive amounts of leakage into that interstitial space. Okay, so we'll talk about venous insufficiency and how we really can identify venous insufficiency with our patients, because there are some pretty telltale signs that, again, we're going to discuss in just a few moments. Then we also have lymphedema. So this is impaired lymphatic drainage, which causes protein-rich fluid accumulation. So this can be caused by a number of different reasons, and we're going to discuss those too. We're going to discuss primary lymphedema versus secondary lymphedema in just one moment. really important to know that with these systemic illnesses here, compression can possibly be used, but we need to really take extreme precaution here, okay? Because if we compress, let's say at the lower extremities of a patient with heart failure, we're going to push all that fluid back up towards the heart more proximally, and that's going to place even greater load on something that is like an already failing organ. So if our heart is already really insufficient at cycling, all of this fluid through the system, and we're pushing more fluid up more proximally to it, it's going to overload the heart even more. So whenever we see edema we're going to definitely focus on this one as well. With heart failure, maybe compression isn't the best modality for that person, okay? But when we have venous insufficiency or lymphatic insufficiencies, we really should use compression, okay? That's the gold standard that we're looking for. Obviously, we want them to be active as well and not just rely solely on the compression, but we should definitely use compression with those patients, okay? Not so much for our patient with heart failure. We don't want to further overload this already failing organ. So I hope that makes sense to you. Okay. Some other common causes of edema. We may also see edema that is caused by exercise, trauma, surgeries, burns, or infection. So that's very, very common to see edema forming after, excessive amounts of exercise, where we have significant amount of blood flow to the area. We get a lot of capillary permeability. Again, after trauma or surgery, you're definitely going to see edema in that area. Think about what we talked about with, our tissue healing, right? Our response, our inflammatory period. We have that stage where we have lots and lots of vasodilation, which is trying to, caused by histamines, which is trying to bring some of those white blood cells into the area, those macrophages, the neutrophils. We're getting that phagocytosis. So after trauma or surgery, we're going to see those inflammatory responses happening. We're not going to focus so much on burns in this section here, but you will see quite a bit of this in your pathology class. So maybe come back to this lecture once you get to that burn section in your pathology class, and this will make a little bit more sense as to why you may see edema there. Something that you should also note is this bullet point here. So after airline travel, a lot of people typically see edema. So if you ever are flying on an airplane and it's nice and warm out, so everybody's wearing shorts, you may notice that a lot of folks are wearing these compressive stockings. And that's because you're going to be sitting for a long period of time. That's going to reduce your circulation already, and that is a risk for edema. Just pulling, we get that fluid pooling in our legs, okay? And also when you're flying at 35,000 feet, we have reduced external air pressure. So I know that our cabins are pressurized and things like that, but it's probably going to be a little bit different. So we don't have as much of an effect. We don't have as much of this kind of external pressure to help manage that hydrostatic pressure that we saw earlier. So anytime you see, there was a question on one of your quizzes that discussed airline travel and the possibility of a DVT formation, you really want to pay attention to something like that, okay? So if somebody goes on a travel or on a vacation and they're traveling for long periods of time, they have lots of edema in their legs, that may be something that you would like to educate your patient on and say, well, these are the signs of a DVT. Not saying that just airline travel is and edema is, but here is what you need to look out for. So if you start to feel significant pain that doesn't really go away once you're seated, and your calf gets really warm and it looks red and it's swollen, that may be a time to discuss with your physician, the possibility of a DVT. And they can go in and do a few things to check that, like a Doppler imaging test. Okay, so really pay attention to this. I'll probably throw a question on a quiz that looks similar to that, that last one that you saw. Okay. Okay, so let's talk about this edema, which is caused by venous insufficiency. So let's just kind of address these first few bullet points here, and then we can discuss a little bit more of this venous insufficiency. So let's just talk about some of these pressure gradients, okay? So when we are sitting and we're at rest, the resting pressure in millimeters of mercury in our system, our venous system, is about 90 millimeters of mercury. Not too bad, right? So we have some resting pressure that is helping deliver this fluid back more proximal to the heart to be recycled into our system. But whenever we are actively pumping our ankles using our gastroc and our soleus, you can see that this creates a much larger pressure. So 200 millimeters of mercury of pressure outside the veins. So that's really going to limit the amount of hydrostatic pressure pushing that fluid into that interstitial space. So by all means, if we're looking at that person that is sitting on an airplane for a long period of time, well, maybe we're going to educate our patients on this portion and say you should really be, doing some ankle pumps, just doing some heel raises essentially, even if you're seated during that long flight, because we're going to get a significant amount of pressure outside of those veins that's going to help return the fluid back to circulation. Okay, so we have these really big muscles that provide a lot of different pressure to those veins. Okay, so that's excellent. After we have these contractions, the pressure typically falls a little bit to allow those veins to refill. So as soon as we push it out, it's almost like a milking action, right? We're going to push out this fluid, we're going to push it more proximally, and then we're going to get this relaxation period where our veins are under less tension and less pressure. And that's going to allow those veins to refill, and then we're going to complete more contractions, and we're just milking that fluid back up more proximally into circulation. So again, we're going to look at this milking action here. And we didn't really discuss this portion yet, but we also have a few different types of compression that we can use. So intermittent compression is something that is going to provide more of a milking action here. Or we just have like a static compression, which is what we're going to really learn with our ACE wrapping and those kind of things. But the game ready that we saw earlier is an example of an intermittent compression. It goes to the most extreme pressure, and then it relaxes some. And then it goes back to that extreme pressure, that high end pressure again. So those are typically better at creating this milking action and more efficient at returning that fluid into, or providing that, the milking action, getting that fluid out of the peripheral system, okay? And we've talked a lot about this word already, but here's a definition for you, phlebitis. So we've talked about thrombophlebitis as being a contraindication for a lot of our modalities. Well, what is phlebitis? Basically inflammation of those veins, okay? This is the most common cause of a venous insufficiency. So whenever we have inflammation present, this really affects the overall quality of our veins. So if we have, let's say prolonged inflammation of these veins, the walls of the vein typically tend to get hardened and less elastic. So that really decreases its ability to flex and contract and dilate more. So we're basically narrowing the section of our vein in which blood can flow, or this lymphatic tissue can flow. So phlebitis is something that you just need to, if you're wondering why this is always a contraindication for a lot of our modalities, it's because it can cause venous insufficiency, and this leads to DVT formation. Okay, so we really need to look out for this. And here's a nice little example of what venous insufficiency might look like, a nice little image here for you. So you can see here we have our blood flowing in one direction. This is our normal healthy vein. We get our blood flow going here. We have these nice little valves that will allow blood to flow through. And then they close off whenever your heart is on a relaxation period, right? When it's not pumping, or whenever your muscles aren't contracting. So it kind of is this nice sequential proximal flow. If we have something like thrombophlebitis, or in this case a varicose vein here on this side, we can see that this valve isn't really doing the job that it's supposed to do. So does it allow blood to flow more proximally? Well, yeah, it still does that. But if it can't close during that relaxation period of that cycle of the heart, then we also get backflow. So backflow is something that we do not want, right? That means this valve isn't doing its job. This is where we're going to get a lot of pooling here, kind of in these distal extremities. And then we have this increased hydrostatic pressure happening in this area. And then this will leak out into that interstitial space again, leaking out into that interstitial space. So that's something that we don't want. So if you see your patients with varicose veins, maybe you can educate them again on maybe using something like compressive stockings or something like that to help prevent this backflow into the peripheral, distal peripheral system. And again, here's just another image in case you didn't like that first one. So healthy vessels versus unhealthy vessels. You can see the valves open, you get that nice little blood flow, and then they close, and this prevents that backflow from happening. Okay, nothing's getting back this direction. Nothing there. Okay. Whenever we see this unhealthy valve, yeah, we get that blood flow going proximal, and you can kind of see here we have these nice muscle contractions that are helping with this. But as they relax, those valves don't close, and we get this backflow here. Again, this is what's going to lead to leakage into that interstitial fluid there. Let's talk about some of the symptoms of venous insufficiency. So again, something that you may have already discussed in your pathology class are signs and symptoms of this, okay? So here we see our varicose veins over on the side. That means that there's damage to that vein, and it's probably allowing backflow, okay? This leads to pooling in the area of that lower extremity, and we get darkened, hard, leathery skin and lots of swelling. And maybe I'll give you a second to think about what this is called. So a little Jeopardy moment here. Hopefully you came up with the right answer. This would be your stasis dermatitis, or venous stasis dermatitis. Okay, so this is what you would see. This is a common clinical presentation that would lead you to think that this patient has something like venous insufficiency. Some of the other symptoms that your patient may experience: pain and heaviness of that affected limb. Of course, if we have tons of edema build up, there's lots of fluid accumulating here. That's obviously going to increase the weight of that limb. So they're going to feel pain, maybe because we have so much pressure in here and it's not allowing for blood to get to that distal extremity, or at least new blood with new nutrients and oxygen, and it's going to feel heavy. They may also experience something like restless leg syndrome. They may experience leg cramps or spasms, and they may get this pruritus or itchy skin. Okay, so venous insufficiency, you should probably know this one right here. I will definitely be asking you questions on this right here. Okay, so you need to know what venous stasis dermatitis is, what it looks like, and that it is because of venous insufficiency. Okay, so let's talk about lymphedema a little bit here. Like I mentioned earlier, lymphatic vessels are found almost everywhere in the body where blood vessels are. What causes lymphedema? Well, we're going to talk about the different types of lymphedema here in 1 second. But basically what it boils down to is that hydrostatic pressure is greater than the oncotic pressure. So we're getting lots and lots of that leakage from this is our capillary here, into the interstitial space. and it is overcoming this oncotic pressure, which drives tissues back into the capillary. So hydrostatic pressure is greater. Some other things that we're going to look at is this low serum albumin. There may be lymphatic obstruction, abnormal lymphatic vessel distribution, also maybe even just reduced activity. Those things can all cause lymphedema. So this is a lab value that you really need to know here. So here's our normal plasma protein level, 6 to 8 grams per deciliter. If it gets significantly lower than this, then our oncotic pressure drops even further. Remember that oncotic pressure really depends on these protein plasmas. So if it can't pull the fluid back into the capillary because there are no proteins in the blood, then it's just going to continue to leak, and that hydrostatic pressure gets greater and greater and greater, and that leads to more of this peripheral edema. So you need to know this normal level here, okay, 6 to 8 grams per deciliter. I would also know this part as well, just a little anatomy piece here. So when we're talking about lymphedema, we kind of mentioned this earlier and we saw this exact same image, but the lymphatic vessels of the right arm come up and they terminate in this right lymphatic duct right here, okay, and empty into that right subclavian vein. The lymphatic vessels from all other areas terminate in the thoracic duct over here, and they empty into the subclavian vein, okay? So, you know, important to know and understand your anatomy. Definitely not the most important section here for our lecture and our discussion, but you should probably know this piece. Okay, so let's talk a little bit about the different types of lymphedema. So we have our primary lymphedema, also known as Milroy disease. This is basically a malformation of that lymphatic system, which is present at birth, or it presents very early in life. So something that is more along the lines, genetics not the right word I'm looking for, but this is typically something that we can't really avoid. Okay, with this primary lymphedema, protein reabsorption across the vessel walls is slowed. So again, that's going to lead to greater hydrostatic pressure and more leakage into that interstitial fluid. Then we have our secondary lymphedema here. This develops due to damage or obstruction of the lymphatic system. So typically we'll see this happen because of a lymph node removal. So mastectomy is something that is going to really affect a large percentage of our population. So because they're taking that breast tissue out, a lot of times, if it's affected the lymph nodes, they have to take those out too. And that's going to really affect how their body is able to recycle that lymph fluid. So sticking with this secondary lymphedema, we have this next one here called filariasis. And this happens, thankfully, not in the US so much, but basically what happens here is there's an infestation, there's a parasite that affects our lymphatic system. So not so common in the US, thankfully, but more of like a parasitic type cause here. The other one that you're going to see a lot of in clinic, most likely, is this one here, which relates more to radiation therapy, infection, or trauma. So again, when we see our patients that are going through radiation therapy, it's important to note that radiation therapy is not a selective type process, meaning that it's not going to only select those cancerous cells, those tissues. It's going to also damage some of those healthy cells, including possibly the lymph nodes. So secondary lymphedema is probably more along the lines of what you're going to be treating most commonly in the clinical setting, but there are some cases of this primary lymphedema or Milroy disease that you might come across. Okay, so let's look at some of these adverse consequences of edema. And do you remember what this is called? Hopefully you do. Second time around, you're seeing it again right there. But some of the adverse consequences of edema include restricted range of motion, include pain, include disfigurement, possible ulceration, which would happen along this section here, possible amputation, itching, or pruritus, brown skin pigmentation, which is venous dermatitis, you got it right, hopefully this time, and of course, functional impairment. So it's really important that we treat edema because, I mean, look at all these adverse consequences that our patients are going to have to deal with. There are a few different methods of measuring edema. So we're going to look at this pitting edema scale. We have a little chart coming up that kind of just walks through the scaling, I guess, that we would see. There are also other ways that you can measure edema. So pitting edema is something that we're going to do in clinic. We're going to push onto the skin. We're going to see how fast that edema rebounds, essentially, and then we're going to give it a score. Another way that we can measure edema is a volumetric measurement, which is typically viewed as the gold standard right now. And I linked a video here, so you can go ahead and click on that video and watch that. Pretty interesting. This is going to be, really sensitive to changes in volumetric measurements. So better than we can do with the circumferential girth measurement, even though there is some good evidence to show that the figure 8 measurement for ankle edema is pretty good. We can actually measure that with some pretty good reliability. So there's another video that shows that figure 8 measurement there that you can click on. And then the other one that I find pretty cool, and I think may, I don't know, don't quote me on this, but may kind of take the place of this volumetric measurement is pyrometry. So this uses infrared light lasers to scan the limb, and it gives you a pretty good understanding of the changes in the volume change, in that volumetric change. So, maybe this would be best for large limbs, so like a full leg versus something like with this gold standard, I'm sorry, with the, well, yeah, even with this gold standard method and the circumferential measurement, you'll kind of see what I mean. The volumetric measurement is good for small joints like the ankle, the hand, but probably not so much for an entire limb. And you'll see why with the setup and everything like that. But circumferential measurements, girth measurements are still really, really good. And if that's all we have in our clinic, as a tape measure, then that's fine too. And we're going to practice some of these circumferential girth measurements in our lab. But watch the video on the pyrometry too, because it's a pretty cool technology that I feel like is becoming more and more popular, especially in specialty clinics. So let's look at this pitting edema scale. Again, I linked a little video right here so that you can go watch just a very short example of what pitting edema looks like. But we have our scoring system here and we have our presentation on the right. This is something that you will need to star and know, okay, this pitting edema scale here. So we have our scoring of +1, which presents with mild pitting, slight indentation of the skin, but it disappears rapidly, so that skin rebounds really quickly. Getting into our +2, now there's moderate pitting. The indentation subsides within 15 seconds, so it takes a while for that skin to rebound. And in the video, maybe you can do your own little measurement here and see what you would score it as. +3 here, deep pitting, indentation lasts more than 30 seconds, so it's getting pretty severe here. And then +4, very deep pitting, indentation lasts for longer than 2 minutes, okay? So go back up here and watch this video that I've linked, and maybe you can come up with your own score and try to score based on this scale here. Okay, now let's talk about prevention of deep vein thrombosis, or deep venous thrombosis, so DVT. So for all of our patients that have edema, they're going to be at risk for developing a DVT. the risk for DVT increases with reduced local circulation. So we looked at those nice little images that show venous insufficiency, right, where we have backflow back into the peripheral system. That's obviously going to reduce local circulation. So that's going to increase the risk of DVT formation right away. Okay. Remember that compression can increase circulation and reduce the risk of DVT formation, but it is not used to treat an active DVT formation. We don't want to cause more compression in an area that's already inflamed and has a clot there. We don't want to necessarily increase circulation at that moment, because if this guy breaks off, right, if it embolizes, it can travel to other areas of the body, end up as a pulmonary embolism, and that is not good at all. Okay, so it's important to know that it can reduce the risk of DVT formation, but we're not going to use it to treat an active DVT. Okay, that's something completely different. The effect is greatest when used in combination with other forms of DVT prophylaxis. So maybe if your patient has a poor clotting time, okay, or just an abnormal clotting time, let's say that, we need to use these prophylactic type interventions. So yes, I would say compression is great, but we also need to teach them, just something simple like that ankle pump, where we saw the greatest increase in pressure in the lower extremity, that 200 millimeters of mercury, just because we're pumping our gastroc and our soleus. So medication plus activity plus the combination of this compression therapy is probably going to be the best bet for this person. Okay, and here are some of the risk factors for a DVT formation. So cancer, central vein catheterization, transvenous pacemaker, prior superficial vein thrombosis. So that's why we always ask if there's a history of DVTs as well. Varicose veins, use of oral contraceptives. This one's been studied quite a bit. Pregnancy and hormone therapy. Those all increase the risk of this possible DVT formation. Remember, compression is not used as a treatment for DVT. It's used as a modality to help reduce DVT formation. You may also want to star this slide. Okay, so this is our Wells criteria. This is basically a little tool that you can use to help rule in, rule out the clinical probability of a DVT. And when I was a student in my first 2-week rotation, we used this on one of our patients. So just to give you a little backstory here of what was happening and why we used this, we had a patient that came in with a total knee arthroplasty. She was not very active. She was enjoying the fact that she got a knee replacement, but she wasn't doing much of the physical therapy outside of her 1 to 2 sessions per week to help manage edema and get stronger again and improve her range of motion. So we had this lady who maybe fit some of these clinical characteristics pretty well. She also only spoke Spanish, which for me was something that was very difficult, because your patient's presenting with some of these characteristics, and the language barrier really I guess just hindered my ability to educate her on the importance of staying active and doing these certain things to decrease her risk. Luckily, my supervising PT spoke Spanish, so it was good. We worked together on that. We collaborated well. But she called in over the weekend. She was having some chest pain, and she said that she was going to the hospital. We used this tool. We ultimately came up with this decision that it was unlikely that she had a DVT based on our score over here. So we sent her home. And then she called over the weekend saying that she had a hard time breathing, she had chest pain, which are, again, characteristics that DVT is embolized and is now a pulmonary embolism. Well, luckily, she ended up not having a DVT and she was having more of a panic attack. So this was a good tool for us to use in our clinical decision making. Should we send this person back to their physician to get a Doppler imaging test performed? So it was, you know, a little scary for me as a student, definitely scary for my supervising PT as well, because he was my clinical instructor at the time. But we use this in clinic, and it's a really good tool to help determine the probability of a DVT. Can that be wrong? Yes, it definitely can be wrong. But it's a good tool to use if you are just unsure. And remember that it's never the PTA's final decision to say, go to the doctor, do this, do that. We're always going to collaborate with our supervising PT. But you can see some of the questions that they ask. Is there active cancer? We saw that that was a risk factor. Do they have paralysis, paresis, recent plaster immobilization of the lower extremities? Were they bedridden for 3 days, or was there a major surgery within the last 12 weeks? So some of those we answered yes to. Is there localized tenderness along the deep venous system? We answered yes to this one. She was complaining of pain in that leg. Her entire leg was not swollen. Her calf was not swollen. Maybe she had some edema in her knee from her TKA, but those weren't present. She did not have pitting edema. Were there collateral superficial veins? Nope. Was there a previously documented DVT? Nope. And is there an alternative diagnosis at least as likely as a DVT? So that one you can actually, you know, take some of those points off. So they may have got this backwards here, but depending on this score, if you add it up, right, greater than 2, likely, less than 2, probably not going to be a likely DVT. But it's good to know the name of this little scoring system here, this clinical evaluation tool, because you may need to use this in your documentation if you suspect a DVT. Just remember that you're going to collaborate with your supervising PT as well. It's not our final decision as a PTA. So here's a clinical presentation of a DVT. So you can see this leg here, definitely very red in comparison to this one here. Looks swollen, but besides that, we don't really have much to go off of. So then we also have this nice little video over here, which is looking at a Homan sign. So you can see this clinician is putting the ankle into dorsiflexion, and they're also squeezing that calf. They're looking for that pain that the Wells criteria was just talking about. Okay, so we're going to talk about sensitivity and specificity a little bit later, maybe next semester, and what those scores really mean. But using the Wells scoring plus a Homan sign, you're trying to really paint a picture and determine if the likelihood of a DVT is high or is it low. Okay. Also, on this other patient over here, you can see they're wearing some kind of compressive stocking. They may be bedridden. So we really need to look out for this with our patients who are bedridden. And this is a pretty cool image of a Doppler. So if there was restriction in blood flow, you would see that somewhere in this region. But if your supervising PT refers them back to the physician for a Doppler imaging test, this is what they're going to look at. Is there obstruction here? Is it here? They'd be able to see maybe that clot forming in this region here. And then it would be more of bed rest, medications like an anticoagulant or a blood thinner or a blood clot dissolver medication. Okay, so back to venous stasis ulcers here. We've talked a lot about them, but here's our first official slide. So what is a venous stasis ulcer? Well, it's an area of tissue breakdown and necrosis that occurs in areas of impaired venous circulation. So compression is typically viewed as the gold standard for treating and preventing venous stasis ulcers. You know, they can wear these stockings for a long period of time without having to take them off. Okay. I would also add that exercise. Let me see if I can do this with my mouse. Yep, I got it. Not great, but Also, adding in exercise is going to be something that is going to help as an adjunct to this compression therapy. We saw, again, gastroc and soleus, how much pressure they're able to produce outside of that venous system. 200 millimeters of mercury. Compressive stockings, we'll see a little bit later. The typical ones that they use, not so much, but we'll look at those ones later on. Multi-layered compression is typically more effective than a single layer, so we can definitely use 2 to 4 layers of compressive wrapping. And of course, like I said earlier, we're going to add exercise and activity to increase the effectiveness of this compressive therapy. I do have a nice video up here that, again, I linked. So in your handout, you can click on that link and see the way that you would wrap a residual limb after amputation to help shape and prepare for functional weight bearing on some type of prosthetic device. So we're going to use our nice little models in our lab to help you guys practice some of these residual limb shaping techniques. We can use static or intermittent compression, but intermittent compression can reduce the residual limb approximately. It's more effective at shaping those residual limbs because of that whole milking process that we talked about. So you can kind of see in here, it's a little bit of a blurry image, but here is that residual limb before the compressive therapy is used, and here it is after. So it makes a big difference on the tissue shape, the form, the healing process. This one is going to be much better to fit into a prosthetic device like this. This one would be, pretty challenging. So we can see how it's working for that patient. Okay, so now let's move on to this next slide here where we're discussing using compression therapy for controlling these different types of scarring. So we have hypertrophic scarring and keloid scarring, and these are things that we had briefly mentioned in some of our first lectures here. So just to give you a little bit of a reminder, hypertrophic scarring is excessive scarring within the boundaries of the original site of the skin injury. Common complication following deep burns and other extensive skin and soft tissue injuries. Keloid scars also form excessive scarring, but in contrast to hypertrophic scars that stay within the boundaries of the initial injury, keloids extend beyond the boundaries of that original site of injury. So we can use something like compression therapy to limit the amount of hypertrophic and keloid scarring. Just remember that normal skin is pliable, it's aesthetically pleasing, and has these clearly identifiable layers, where hypertrophic scars, they're not pliable, they have raised and rigid appearance and do not have those clearly identifiable skin layers. The risk of hypertrophic scarring really increases with delayed wound healing, deep wounds, repeated trauma, infection, or the presence of a foreign body, or somebody that has just a genetic predisposition. So we're going to see a lot of this whenever we're discussing burns and burn wounds. Keloid scars, the risk of keloid scars after injury is largely genetically determined. So we'll talk about that in our pathology class as well, and we'll see who is at risk of developing those keloid scars. But the recommendation to help maybe control these different types of scars, hypertrophic scarring or keloid scars, would be to use a compression device that produces 20 to 30 millimeters of mercury, and we can, our patients can wear those compressive wraps up to about 23 hours a day for 12 months to really reduce the height of that incision, or that scar, sorry. And again, this compression acts as a mold for the new growth of this tissue. So it's basically saying grow this much, not this much. Some of the adverse effects of compressive wrapping include this, they can aggravate skin conditions causing edema. Or I'm sorry, not skin conditions, but they can aggravate a condition causing edema, not skin They can impair circulation with excessive pressure, so it's really important that we use the correct techniques that we're going to see in lab and that I've actually provided you a video with to limit this amount of excessive pressure. We don't want to try to cut off the circulation to certain areas that we're compressive wrapping. We want to do it in a nice gradual manner. So all or the majority of the pressure should be distal. If this is our little foot here, okay, that's pretty good. And we're going to start our wrapping. We want the tightest bands to be here, kind of distally. Let's actually start here. So it's going to be tight, it's going to be tight, it's going to get a little looser, it's going to get a looser, 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 until we finish up top here. So this is the area where the highest compression is used. I'm just going to write highest in the arrow, compression, see? And this is the area more proximal where we want the lowest compression, okay? So we want that milking effect. We want this this fluid to move out of the distal extremity and up into the more proximal areas to be recycled, okay, through our lymphatic system. If we do wrap these compressive wraps too tight, ischemia and permanent damage to those occluded tissues is a possibility. So again, really, really important that we use the correct technique to limit the amount of ischemia in those tissues that we're trying to actually benefit, but we don't want to cut the circulation off completely. Okay, so let's talk about these different types of compression bandaging. This is something that you should star, this slide and the next slide for sure. Whenever we are using compressive bandaging, we have a few different types. So some terms that you're going to need to know is resting pressure versus working pressure. So what is resting pressure? Well, this is pressure that's exerted by elastic when it is put on stretch. Exerts this pressure whether the patient is moving or immobile. So we're going to talk about on the next slide a couple of different types of wraps. Okay? Whenever we're looking at working pressure, this is produced by active muscles pushing against the inelastic bandage. So this is produced when the patient is moving and contracting the muscles. So we would use a bandage with high resting pressure in certain instances, and then we also use a bandage with high working pressure in certain issues or in certain instances. So let's look at these in a little bit more detail. So the first one we see here is this long stretch bandage. This bandage can extend by 100 to 200% and provides high resting pressure. Okay, so about 60 to 70 millimeters of mercury. This is for the person that is not going to be mobile, right? So we need a high resting pressure to really push those fluids out of the distal extremity. Okay. In comparison, we have our short stretch bandage. So this bandage with low elasticity really only extends about 30 to 90%. Okay. So low resting pressure basically means that, you know, when the patient is immobile, it's not doing as much work as this long stretch bandage would. But when they are active and they're actively pumping their gastroc and their soleus, it uses that that low elasticity to push against that bandage, and it creates a high working pressure. So this would be used more for somebody who is still mobile, and we want to have those effects, you know, during exercise or during walking or something along those lines. So you need to know the difference between these two here and when we would use those. Again, a long stretch bandage, it's extending a lot, right? 100 to 200%. That's going to create a lot of pressure whenever we release that bandage and it's trying to go back to its original length. This is better for somebody who is less mobile, right? I can't really write that with my mouse. That'd take way too long, but you need to know that. Short stretch bandage doesn't stretch as much, okay, 30 to 90% beyond its original length, produces low resting pressure, but a high working pressure. So we want this for our patients that are more active. We're going to get more of that pressure gradient because our muscles are pushing against this short stretch bandage, and that's creating more pressure. Okay. And then the last thing here is our Una boot. There's a nice image of this in your textbook, so you can look there for that. But this is a semi-rigid bandage made of zinc oxide impregnated gauze. We looked at different medications for iontophoresis, and this should look a little bit familiar to you, the zinc oxide. So this is applied to the lower extremity to exert pressure, and that zinc oxide is going to help with any type of dermal ulcer, right, for tissue healing. Okay, so the zinc oxide impregnated gauze provides this this pressure of 35 to 40 millimeters of mercury because it's semi-rigid, and it has this medication to help with tissue healing right here. Then the last thing that we're going to really discuss here, as far as different types of bandage, different types of compression garments, would be this anti-embolism stocking. So these are typical. You've probably seen these and not really known what they were, but this is a knee-high or thigh-high stocking that provides low compression force to prevent DVT formation. So 16 to 18 millimeters of mercury is all that bandage is providing for us as far as compression. Remember that we looked at the gastroc and the soleus, and that gastroc, or that muscle pump, provides 200 millimeters of mercury. I apologize for me being slow with this. I need a little bit more practice. Okay, so significantly more compressive force is received whenever we have active muscle pump. But this is a good starting spot. That's why I say we want to use not only the compression therapy, but also educate our patients on being active and not just being a couch potato and sitting there, because this is going to really, really benefit them in the long run. It's going to get a lot more of that fluid out of those extremities. All right, so now we just have a couple different images of these different types of compression bandage systems. So what we're looking at here is a multi-layer compression bandage system. So you can see the first layer going on over the top, and you can kind of see it right in here, this nice little figure 8 pattern. We're going to see more of that when we get into the lab setting. I'm going to show you how to actually apply a bandage using this technique, but you can see that they're applying the second layer there and the third one on top. And just remember that these multi-layer bandage systems are more effective than just a single layer. Oh, I did have a picture of the Una boot here. So you can see this zinc oxide impregnated gauze right there. And then they apply this semi-rigid cast over the top of that as well. So looking at healing dermal ulcers as well as decreasing edema. Remember that the rigid bandages are going to provide a higher working pressure. Okay, so let's talk about some of these contraindications for compression therapy. So you notice here that they talk about intermittent or sequential compression pumps. We're going to treat this as just our main contraindications for compression therapy in general. Okay, so let's look at this first one here. We have symptomatic heart failure or pulmonary edema. So just remember that we're not going to apply compression to an already failing organ. Okay, so if they have heart failure or pulmonary edema, we automatically think of CHF, and we have to really determine, is it left-sided, is it right-sided? If it has been deemed unsafe to perform compression therapy, then we're not going to perform therapy. So if it's going to overload the heart to the point where it's going to fail faster, then we're not going to apply this compressive therapy. Now, there may be some moments where their heart failure is non-symptomatic, or their physician has deemed it safe to use something like below knee compression socks or stockings. So there are moments in time where it is allowable, but for us, remember, we're the PTA. We don't get to really make those decisions, so we're going to treat this as a true contraindication. So symptomatic heart failure or pulmonary edema, right-sided or left-sided. So you may ask them questions like, do you have any heart or lung problems? Do you have any difficulty breathing? Are you taking any medications for your heart or blood pressure? Do you have swelling in both legs? And then you can check for the presence of bilateral edema, because that's typically how it's going to present bilaterally. Okay? So the next one here, we have recent or acute DVT, thrombophlebitis, or pulmonary embolism. So again, remember that compressive therapy is not a treatment for a DVT, but it is a prophylactic measure that we're going to use. So we're going to use compressive therapy to help prevent DVT from forming, but if there is a recent DVT or an acute DVT, we're going to treat this as a contraindication. Remember what thrombophlebitis is. That is not exactly a DVT, but phlebitis is something that is the leading cause of PVD, which can lead to DVT formation. And if they have pulmonary embolism, we're going to say no for that one as well. Okay, so you can ask them questions like, do you have pain in your calves? How long have you not been walking? We want to get there. We want to paint the picture on if they're being active or if they're not being active. So those are some questions that you could ask them. Just remember too that there's that Homan sign that we looked at earlier, which is basically discomfort in the calf on forced dorsiflexion of the foot, and with that palpable pain whenever you squeeze their calf. Okay, that's a sign of thrombosis in the leg. And we also looked at the Wells criteria for scoring the likelihood of a DVT. So use some of those clinical tools and your assessment to maybe help, I'm not going to say rule it in or rule it out, because that's the supervising PT's job, but at least collect data on that to report to your supervising PT. If there is obstruction of the lymphatic or venous return, then we're going to say this is a contraindication as well. So you can ask your patient, do you know why you have swelling in your legs or your arms? Is something obstructing your circulation? A lot of times they're not going to know, but it could be that this lymphatic or venous flow is obstructed by a thrombus, by radiation damage to lymph nodes, those kind of things. So we're going to treat that as a true contraindication. The next one here is severe PAD or peripheral artery disease. So if they're already having a difficult time, if their body's already having a difficult time getting blood, getting oxygen to those distal extremities, it really wouldn't make sense to apply any type of compression over that, because we're now pushing more of that fluid out, right? We need oxygen, we need blood to get those to those distal tissues. So compression is actually going to have the opposite effect of that. So we need to make sure that they do not have peripheral artery disease, okay? So a question that you could ask them would be, do you get pain in your calves when you're walking? What we know about PAD is that when you increase the demand for the muscles, like your gastroc and your soleus, they require more oxygen and more blood. If somebody has peripheral artery disease, then that increased demand is going to still be there, but they're going to have less and less oxygen, less and less blood to those areas. So they're going to get pain due to ischemia, right? We're increasing the demand for oxygen. Oxygen can't get there. Well, that's going to result in pain, especially with movement. And once they sit down, is it relieved? If yes, then that's a pretty clear indication that they may have this peripheral artery disease. Also, if there's an ulcer present, you may ask them a question like, have you had problems with your arteries? For example, heart bypass surgery or bypass surgery in your legs. Okay, and we're going to talk about what's called an ankle brachial index, so ABI. This may be something that you need to replay a few times, but if the measure, we'll talk about this in lecture a little bit more, but ABI is a measure of essentially two different blood pressures, one in the upper extremity and one in the lower extremity. We want those to be really close to each other. Okay, so if we take blood pressure in the upper extremity and we get a blood pressure in the lower extremity, and that blood pressure in the lower extremity is much lower, then that means that we're not getting as much blood pressure to that area. So if the ABI is less than 0.6, that indicates blood pressure at the ankle is less than 60% of that in the upper extremity. That means that there's not a lot of blood flow getting there, okay? So ABI, I'm going to write this right here. I apologize for my handwriting. Less than 0.6. Compression is contraindicated, okay? Also, if there's any local skin infections, we're not going to place a compressive wrap over that. Remember that part of the effects, or at least one of the something that you're going to see due to compression therapy, is that it's going to increase tissue temperature. Well, if there's an infection present, that's not necessarily a good thing, right? We don't want to create more of an environment for something to continually grow and possibly spread that infection. If there's significant hypoproteinemia, remember we looked at the normal levels earlier. If there's significant hypoprotein anemia, less than 2 grams per deciliter, then compression is contraindicated. Remember that the normal ranges are about 6 to 8. Okay? If there's an acute trauma or fracture, again, we're not going to compressive wrap that limb. Or if there's arterial revascularization, we're not going to compress that area as well. As far as documentation goes, we'll spend a little bit more time on this, but we typically want to use, we want to put in our documentation the type of compression. We looked at those different compressive bandages, right? Ones with high working pressure or low resting pressure, some things like that. We want to make sure to put that type of bandage in our documentation. Obviously, the area of the body that we're compressing and applying this compression to. Patient position might have an effect as well. If you think of the patient that has PVD, you may want to elevate their legs in order to get that return back more proximal. If the patient has arterial disease, well, that's a different story. But the position definitely matters here too. If you're using something like a pump, the inflation and the deflation time, so if you're using like a intermittent compressive device, you would want to essentially document the on time and the off time, if you can think about it like that. The pressure at which you're inflating that cuff to, the treatment duration, and the response to the intervention. So using your measurement tools that we talked about earlier, the girth measurements, those kind of things, you'd also want to document. Is this a good treatment for this person? How do we know? Well, we know by the response to the intervention. Okay, so gonna get into a little bit of detail here with these different medications. Some of the ones that I kind of want you to, at least for now, group these two together, these diuretics. So diuretics help to get rid of excess fluid in the system. Okay, we're trying to decrease edema. And we know that that hydrostatic pressure gets really, really great when we have excessive amounts of fluid in the system. So diuretics are basically used to get rid of those fluids. So the real common one that you may see is Lasix here, and Bumex there as well. And you should also take a peek at these adverse reactions. So if we're getting rid of a ton of fluid, we're urinating a lot, we're getting rid of a lot of fluids, there may be an electrolyte imbalance that shows up. Your patient may be dehydrated. And since we're getting rid of a ton of this fluid in the system, that's going to also decrease our blood pressure. So you're going to have to be really, really cautious of your patients with positional changes, right? We've talked about orthostatic hypotension. This is going to be a really common symptom that you're going to have to manage in the clinical setting. Okay, so you can kind of see the same thing here. The only one that I would also kind of add to that is this increased urination. So diuretics, we're trying to get rid of fluid. We're trying to get rid of it, okay? We're trying to decrease the amount of fluid that we have in our system. So diuretics can help us do that, but you have these adverse reactions here. So kind of group those two diuretics together. I'm not going to make you understand the differences between these two here. Then we have ACE inhibitors, so you can see these medications here. Okay, you're going to need to familiarize yourself with those. The primary use of these ACE inhibitors is just to improve circulation and reduce venous pooling. So some things that you might see because of that is, again, low blood pressure, a cough, and maybe kidney dysfunction. Okay, we'll talk about this in more detail whenever we start looking at our cardiac section. ACE inhibitors, it'll make sense as to why you see kidney dysfunction with these ACE inhibitors. As far as calcium channel blockers go, you can see these medications here. And it's really nice because each medication class, you can see that all of these medications end in the same 4 letters, right? Same kind of thing here with these calcium channel blockers, ending in PINE. This helps to manage blood pressure, these calcium channel blockers do, but it could cause edema. So if your patient is taking calcium channel blockers to help manage their blood pressure, and they're a good candidate for compressive wrapping, well, we just need to know that this component here may be kind of playing into their edema. So possible adverse reactions include peripheral edema, dizziness, and flushing. Okay, and don't worry so much about this one down here. We'll talk a little bit about this doxycycline, but you know, this one's used for anti-inflammatory effects for lymphatic conditions, and we can see these adverse reactions here. I really want you to know right now these diuretics. Okay, again, we're going to talk more about ACE inhibitors and these calcium channel blockers when we get into our cardiac section for therapeutic exercise. So you'll see these ones again, you'll see these two, but for now, I really want you to focus on these diuretics. And here are some of the commonly used CPT codes with compressive type devices. So you can see the code here. So this is the code that we would bill. We have our description here, so 29580, application of an Unaboot with that zinc oxide paste. Again, really to help with venous insufficiency and or wound care. So that zinc oxide is really going to be beneficial for these wounds, and the actual rigid, semi-rigid boot that they have on is going to help with this venous insufficiency. 29581 is our application of multi-layer compression. So again, used for venous insufficiency. 97016 is a vasopneumatic device, so something along the lines of that Game Ready that I showed you earlier on. It's not quite the same as most of the vasopneumatic devices, but this is used for intermittent compression. Okay, and then our last one here, 97535, self-care home management training. So including patient education, including compressive wrap techniques, you could bill this code while you're educating maybe somebody like a caregiver on the correct way to compress that limb. And that brings us to the end of our lecture. So I really hope this was helpful for you all. If you have any questions, feel free to reach out to me directly. But go back, look at these notes that we took here. And if you have, like I said, if you have questions, feel free to reach out, and I will see you all soon. Thanks.